What is going on, Disc Golf Strong Performance Academy? We are so excited about tonight. We have a special guest on this special Performance Academy Live. We are going to have a great friend of mine, a great disc golfer, Dr. Branden Garland, joining us. We're going to be talking about disc golf injuries. We're going to be talking about disc golf injuries. What are the most common disc golf injuries? We're going to be talking about prehab, the importance of prehab. So that's before injuries happen. Yes, Jennifer, thank you. Thanks for being here. And your posts are coming up. Awesome. And also rehab, some of the common rehab methods. And then we're also going to be taking your questions. So I'm going to bring Dr. Branden in, and then we're going to get to know him a little bit, and then we'll go into the question, or we'll go into tonight's topic, and then we'll answer questions at the end. Feel free to ask questions anytime. If I'm not going to be monitoring the questions in the moment, but if I see and there's a question that's really pertinent to what we're talking about, then I'll bring it in. If not, we're going to make sure we'll get to all the questions at the end. So Dr. Branden Garland, like I said, he is a great friend of mine, both personally and professionally. We've been working together for a couple of years now. He is out of Oregon, great disc golfer, and he's a sports chiropractor. I'll let him get into telling more about him. He's also on the Disc Golf Strong Medical Advisory Board. So great to have him. So let me bring in Dr. Branden Garland. What's up, Branden?
Hey, Seth. Thanks for having me.
Hey, glad to have you here. Super excited about tonight. Not as excited about the topic, and I don't mean, when I say that, I don't mean like I'm not like pumped about sharing information about disc golf injuries. It's just such a tough topic because there's so many disc golf injuries, and no one likes to have the injuries. But we'll get into that first. Why don't you share with everybody tonight who you are?
Yeah, thank you. Well, I'm a chiropractor, sports chiropractor, coming out of Oregon, originally from New Jersey, but I moved out here back in 2012 and started practicing right away. I actually moved out here for a job, so I worked for a few offices before starting my own practice, which I started back in 2017. So I own Oregon Sports and Family Chiropractic out of Newberg, Oregon. And we do specialize in a lot of sports injuries. We treat a lot of athletes in the community. We have a couple local colleges and some good high school programs nearby. And then disc golf is a big part of my life. I've found disc golf about 6 years ago, joined the PDGA, been playing tournaments since, kind of working my way up through the advanced ranks, but Oregon has a great advanced field, so a lot of good players out here, but always have fun when I get out. And yeah, it's been a blast ever since. Had some great experiences with you working some tournaments, treating some pros and AMs alike, and getting some amazing experiences meeting amazing people. But I love the sport, happy to be here. And, this is kind of blending my two passions of chiropractic and disc golf. So I appreciate it.
Absolutely. No, I'm so glad you're here. And it works, it blends so well together, especially too with, one thing about, Dr. Branden is he's actually part of a group called like Forward Thinking Chiropractic, right? Or Forward Thinking, right? And so he's always, is that the right, it's Forward Thinking?
It's the Forward Thinking Chiropractic Alliance, or FTCA, little small plug. So if anyone's actually looking for a good provider, it's one of the maps and one of the referral sources that I use. So FTCA, you could search for that in Google and find, generally you're going to find evidence-based, more forward-thinking chiropractors who either specialize or understand realistically how to treat injuries.
Awesome. And we well, no, it wasn't recent. It was last year. Branden and I got to spend a couple days together. Got an Airbnb in San Francisco and did a course called Postural Respiration.
It was
a
year ago this weekend. A year ago
what?
today. Yeah.
No way.
So November 2nd to 4th.
Oh, wow. It's all about respiration, the breathing, diaphragm, everything that's going on from like here to the hips, right? And how it affects everything else. And then you just you're just finishing up your certification with one of my mentors when I first got into the strength and conditioning, Mike Boyle, with his certified functional strength coach certification. So you're just wrapping that up, huh?
Yeah, I was actually at the office filming 4 videos. I did kettlebell deadlift, split squat, push up, progression, regression, and I believe I did. There was one other video, and that was all for my practical. So you send in 10 videos of your whatever they're asking for, and then a little written explanation. But I like the system because it's good that they get to kind of see their trainers and vet their trainers that they're allowing into their program.
Yeah.
But to me, this program has been kind of the closest link between rehab and fitness. And so it's been a great entry into training for me. It's been really
Yeah.
exciting.
That's fantastic. And the certification that Branden is getting, this certified functional strength coach certification, that came from Coach Mike Boyle and his philosophy. And like I said, he was a mentor of mine when I was starting out and still is. And really, a lot of the disc golf strong philosophy and why I do things and why we structure comes from learning a lot from Coach Boyle. I remember Coach Boyle many years ago. He was saying, if I was to walk in and watch you training your athletes, you should be able to explain to me why they're doing every exercise they're doing, and not just say, oh yeah, coach, today's just a random day. I just, they're randomly doing this and randomly doing that. Right. He's like, you better have a reason for why you're doing things, and not just put random acts of movement together and call it a training program. Like, it's got to actually be able to transfer, because when he has his athletes running through his facility, or if he's with the Red Sox, or if he's working hockey or Olympians, like, everything has to have a purpose, or why even have it in there, right?
Right.
So I'm so glad, and I know you see that in his certification course, the Certified Functional Strength Coach course, is everything has to have a purpose. And also, what I loved that I got from Coach Boyle was logistics too. Is the importance of, like, I can go and you can, any of us can go on YouTube and watch, and we can find 7,000 different exercises to do, right? Or more than that, probably now, right? But Coach Boyle would say, not only do I have to have a reason for doing this, but also, if this exercise is so good that I'm going to add it into my program, what am I going to take out? Because if I just add everything in, my athletes are going to be training like, 26 hours a day, right?
Right.
That's just not possible. So
Yeah.
so
Everything
that's
has its place. Everything has its purpose. Yeah. You look at his training protocols, either adults or athletes, it kind of follows the same flow and the same reasoning, and it makes it, in a way, it's a complex model that makes it very simple, and in a way you can apply it to many things, but
Yeah.
it makes a ton of sense for disc golf for a lot of reasons.
Yeah, absolutely. And for everyone who's listening, you're like, why are we really getting into, Coach Boyle's, training philosophies, and how does that relate to what you're listening to tonight? Branden and I talk about, and it really does relate, because on the topic tonight, not just injuries, okay, but also therapies, prehab, rehab, right? Knowing that you can go and you can plug into Google, and you can find like 100 different ways to try to heal something or work on or improve on something, right? But what you really want to know is take all the fluff out and make sure that the things that you're going to be able to use, they're thought out. They're there for a reason, so that the information that I'm sharing, the information that Dr. Branden's sharing, that's things that, yeah, you could add this, or you could add that, you could add this, you could add that, but you could be rehabbing, 7 hours a day using 45 different therapies, and rubbing things on your shoulder and this and that. We don't know how much works or doesn't work with those kind of things. We're going to stick with things that are actionable, that can make a difference. Now, mileage is different for each person, right? Some people are going to find better results using this versus that. There is some individuality there, but that's kind of why, kind of ran with the Coach Boyle thing. Philosophy is that when we're talking about injuries, when we're talking about prehab, we're talking about rehab, we want it to We want to know that there's thought behind it. It's not just, yeah, just do this, right? So, all right. So let's get into injuries. Like I said, it's not a fun topic, but it's an important topic. And when I first, when I first started getting into disc golf as a strength coach, one of the first things I did when I looked up, I typed in disc golf injuries into Google. This is back in 2015, and a study popped up from the University of Arizona, and they did as research. They studied like 897 people, I think it is, disc golfers, and they
Right.
found that more than 81% of respondents had said that disc golfers had said that they had suffered an injury playing disc golf.
Right.
And I
And
was
that was
like,
surprising. Yeah. Yeah. That's
right?
mind blowing, right? You think how much repetition is in our sport and all that, but you think, well, we're healthy and we're not really impacting anything and all we're doing is throwing. So, really what could go wrong, right? And then you see a statistic like that, 8 out of 10 people. Yeah, it really makes you think. And I think, obviously with Disc Golf Strong, a lot of that inspiration, I think you said, came from seeing that article.
Yeah. Yeah, absolutely. And knowing that, when in the beginning when you were first with putting out with Disc Golf Strong, and yes, people are like, oh, we're not athletes and this and that, and we're not, you know, uh, we're not really using muscles. I mean, you hear so many different things, like
Right.
we're not, we need to be fluid. And the thing I say to that is, always like, if you see a Bentley driving down the road, you're not like, oh wow, that looks so smooth. There must nothing must be violently going on under the hood. Like it is. It's just it's better well maintained, it's better engineered, it's better thought out, right? And better maintenance. I already said that, maintained, right?
Mhm.
Than the car that is barely making it down the street. When you're throwing, there's a lot of force going into there's a lot of force that you're creating in your body, not only creating but absorbing that force.
Mhm.
It may look silky smooth on the outside, but it is not silky smooth on what's going on the inside. So, uh, thinking about the common injuries in disc golf and
Mhm.
how we can manage those is important. So, the first thing I want to talk about before we actually dive into the injuries, and again, thank you for watching. If you have any questions or anything pops up, post them please in the comment section, and we will definitely get to those. But one thing that I know that we both very much believe in, and I first heard this from an amazing physical therapist, Gray Cook, and I know you've heard this too, is putting strength on top of dysfunction,
Mhm.
right? And
Absolutely.
so a lot of people, they'll do training programs and they'll go in and it's about load, intensity, complexity, this and that, and they're not fixing the dysfunction that's going on in their body. So they're just getting
Right.
a stronger, more dysfunctional
Right.
body. What are
You
your thoughts on that?
Absolutely. I think of a patient I had maybe 2 months ago. She's a fit, maybe 40-year-old female, goes to CrossFit and tells me that she has back pain every time that she does squats. And I say, okay, show me your squat. And she goes into a squat and goes into kind of get my hands so into like a back bow, right? And you're not necessarily supposed to overextend your back into a squat. There's some element of flexion or extension within normal limits, but she was showing me a lot of back contraction, which to me says that her brain has developed a strategy of how to lift weight with mostly her back and with back extension. And as a chiropractor, I know that that puts a ton of load onto joints and discs and sets you up for just a bad scenario, wear and tear over time. So that, I explained that to her, made perfect sense why she would have that pain. And along with that, kind of tying that back, the treatment for that would actually be to regress her, to pull her back and teach her how to lift without that dysfunction. You can't strengthen and teach the brain how to lift something on top of a dysfunction, right? Because we're just going to be strengthening an improper pattern or improper group of muscles that are going to start engaging. That could lead to a painful scenario, some sort of overuse, some sort of overcompression, some sort of wear and tear. And that's what we're looking to avoid. So absolutely trying to avoid strengthening a dysfunctional pattern.
Yeah, absolutely. And so, for those tuning in, that's why we really in the beginning, we're working on the core stability, the
Hmm.
mobility, the hip stability, right? And people go, hey, but where do we get to the most intense exercises?
Right.
Some people love where we're at, and some people are probably thinking like, oh, I thought we were like gonna like work out here.
Hmm.
We are, but it's not that type of working out. We are improving the body's way on how it organizes itself and movements and what muscles it's engaging and what muscles it
Right.
isn't. We're trying to get to the root cause, right? Because like you said, like we don't want to put that dysfunction, we don't put on that strength on top of that dysfunction. Now can we operate, can we throw a disc with dysfunction?
Right.
Absolutely,
Mhm.
right? I can drive my car from, here to Las Vegas, 13 hours. I would rather not have the check engine light on and hearing a dun, 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 like the entire time I'm driving. Could
Right.
I make it? Yes, but could I
Right.
also not make it?
Right.
Yes, right? Like,
Right. And
so we
should I
want,
make it?
yeah, right.
Yeah.
So that's where we want to go and say this is why it's so important that we're talking about this first before we get into injuries, is that we need to make sure that we're getting and we're trying to hammer out and get rid of those as best we can imbalances. There's always going to be
Right.
imbalances in the body, right?
Right.
But try to equal out those imbalances a little bit, get rid of some of those asymmetries, and then get to the root cause, right?
Right.
If my tires are wearing all the time poorly in my car, I can just keep going and try to change tires all the time and spend that money, or I can go like actually get the alignment chain,
Right.
fixed, and they go, okay, you're right. That's
Yeah.
the root cause is the alignment, not the tires.
Exactly. It's why we prehab, right? It's why we do disc golf strong. It's why we focus on mobility and stability, because the best thing you can do for an injury is make yourself either more resilient if it happens, because injuries are going to happen. We're not necessarily trying to prevent injury because that's impossible. We're trying to be resilient to them when they happen and be robust when we come out of them. And the body
Mm-hmm.
has to go through a natural process of inflammation, and we just kind of have to ride some of that out, and that's natural and that's fine. So the prehab part of that just makes it so we're that much more tolerant. And instead of a 6 week injury, it's a 3 week injury, something like that. And so, what Seth's really trying to drive home is that the importance of training your body before injury happens, and not just anticipating injury and then saying, well, okay, well, there's something we can do about it. And the prehab is actually part of that.
Yeah, absolutely. And that's why we'll see these posts pop up in the Performance Academy or in the Inner Circle, or where say, hey, I went, and I said there was, I can't remember who it was that just posted this in the Performance Academy recently. They said, oh, I went to my chiropractor and I showed them the exercises, and they're
Mhm.
like, keep doing it, right?
Yeah.
Because a lot of the times, the physical therapist and the rehab professionals, they will get an athlete, or they'll get someone I'm working in, and then they'll be like, oh, okay, we're going to try to do dead bugs, and we're going to do this thing called a bird dog and stuff. And they're like, oh, I already do this. Like, what?
Mhm.
Like, yeah, we're trying to do it prehab.
Right.
So we're not doing rehab. And like you said, injuries happen.
Mhm.
They're unavoidable when we are putting the kind of forces on our body that we are. Things are going to happen, especially too, and we'll talk about posture tonight. When we're going from sitting, a lot of us sitting in you know uh, not good postures. I hate saying the word poor or
Right.
bad, but we're in postures that are not
How about
good for
prolonged
us.
postures?
Love it. Okay.
Yeah.
Prolonged postures, right? And then we get up and we get to the course and we start throwing discs, right?
Mhm.
So um the work that we're doing with the prehabbing and getting your body moving and stuff, that is going to help lower injury risk. And
Yep.
like you said, and I tell my athletes on tour, the stuff we're doing doesn't mean that you can't, like, you won't ever experience an injury. But
Right.
like you said, Brandon, is, hey, if you feel something goes, oh, and you go, okay, Well, that's a 1 week thing, and not a I think the season's done for you
Right.
thing.
Right.
So
Absolutely.
awesome. Awesome. All right. Well, let's get into injuries. Well, first, before we say like, oh, shoulder, the hip, really the first thing that we should be talking about is breathing, right? What's going on here? You and I
Sure.
took a whole course on respiration, right? And there's so many
Mhm.
other things out there about breathing, and in the academy we talk about breathing. So dive in a little bit. Your thoughts on breathing and how it relates to what our body's doing and the positions it puts our bodies into.
Absolutely. It's funny because breathing it's such a deep conversation. My head goes a million places, right? And so just organizing those thoughts and kind of bringing them back, because I think of the mental preparation that breathing gives you. I think of the physical preparation, the reflexic stability in your core that breathing gives you, the positional preparation, and how all those things kind of align to get you to do whatever you're asking your body to do in the efficient, most effective way.
Mm-hmm.
Breathing also allows, let's flip that. When we don't breathe, what happens, right? We tighten. We have a stress response, right? Our body's almost anticipating something. So, in that vein, breathing's all the more important to maintain, I don't know if flow is the right word, but mental flow, physical flow, that sort of thing, right? Um, and so, going back to the core stability thing, that to me is the most important when it comes to the physical preparation and the injury prevention. And we can easily segue right into a low back scenario when we're talking about breathing, when we're talking about the core. But realistically, breathing allows you to use your diaphragm to move air instead of tightening and using neck muscles, chest muscles, upper back muscles, inappropriate muscles that are not only going to strain these areas, but put your shoulders out of position, put your low back out of position, and long story short, make a very injury prone scenario possible. So, um, having the proper breathing through the diaphragm allows you to use your core the way it's meant to have tension in the front of the abs that help distribute essentially stability for your low back. So it's not just your low back holding you up, but you have your low back and then you have your abs that are giving equal opposition for your spine. And that's
Mm-hmm.
essentially how we prevent strains in the low back, excessive joint jamming or ligament stretching or muscle straining is all going to happen when we're in a back-loaded scenario. So that gal that I mentioned who is hyperextended, she starts to rotate. That's a recipe for disaster on a low back, right?
Yep. Absolutely. Absolutely. And our torso position, like you said, it makes a big difference on everything. Like somebody comes to me and they go, one time an athlete on tour, they came up, they're like, oh, I got something going on with my elbow and my wrist. I'm like, okay, let's look at I want to look at your breathing patterns.
Mm-hmm.
And they were like, my breathing patterns. I
Mm-hmm.
told you my elbow hurts and my
Right.
wrist. I said, well, I want to look at your breathing first because many of you are watching, probably seen me do this before, right? Where if my rib cage is elevated, this is as much internal rotation as I have. If my rib cage is down, I slightly brace my abs. This is as much movement, internal rotation as I have,
Mm-hmm.
because the shoulder joint here is attached to my body via the shoulder blade, the scapula,
Right.
and the scapula sits on the back of the rib cage,
Yep.
right? So if my rib cage is elevated, it's going to tilt my shoulder blade back. If my shoulder blade is back, it's going to tilt, or it's going to affect my shoulder joint, which is going to affect how my arm moves, right?
Right.
And the stress is on my elbow. And like you're showing too, if I'm rounded forward, right, and my torso is too down, now my shoulder, my scapular, my shoulder blades, okay, we'll use scapular, shoulder blades interchangeably, but we'll try to stick with shoulder blades as much as we can. So my shoulder blades then now rolling forward and it's open like you're showing, and that's putting stress on there. So we work on our breathing patterns, which helps our torso, our pillar stability, and how it's organized. And Better believe it can have an effect on your elbow. Better believe it can have an effect on your knee, right? Your
It's going to
neck.
tell it's going to tell your elbow where it can live, right? Where your shoulder lives, right? If we're rounded forward and you imagine me kind of rounded forward, well, what does that do to my elbows, right? It internally rotates my shoulders. It puts excessive strain on parts of my elbow. Now all of a sudden we're dealing with an asymmetry where there's, balance is a weird word, but it really is kind of an overuse. It's the top side gets overstressed, the underside gets a little bit weakened, and it's all a positional thing. And a lot of that goes from how we breathe. If our body's comfortable breathing in that position, you better believe that that's what we're going to do when we're calling an immediate need on it, right? In that moment, path of least resistance, the most efficient thing first. And so if we're used to breathing here, that's all we're going to get. So training ourselves on how to breathe in that strong, like you said, pillar prep position or core stacked position, posterior pelvic tilt, so important.
Yeah, absolutely. All right, so let's take it from breathing. We know breathing is important. We want to focus on that deep diaphragmatic breathing, something you want to be working on all the time, daily, right? Now let's take it down from just breathing and let's go to the lower back. There's so many people, so many disc golfers that deal with lower back tightness, lower back pain. A lot of it, they may not use this term, but non-specific lower back pain, right? Because they don't exactly know why, and maybe we don't fully know why unless you go and you get MRIs and stuff. And even with MRIs, you go, it looks clean, but you still got back pain. Let's talk about that.
Sure. So, the whole non-specific thing, so many patients I have, they say the pain just spreads right across the low back, it's belt line, and you can call that non-specific. You wouldn't expect to see anything specific on MRI, and even if you did, that wouldn't necessarily explain diffuse pain, right? If you saw one joint, you would think that's more pinpoint or sharp. So realistically speaking, to me, most back pain is functional. And what I mean by that is it's how you move or how you're breathing or the postures your body is most likely seeing throughout your life and how that affects, essentially your brain's relationship with your low back. Pain, I forget who said it, but pain is an indication that your body is moving something wrong or using your body in an improper way, using that part wrong. So it's an indication, it's a responsibility, it's a check engine light, right? And so most common thing is going to be a little bit of a lack of core, rib elevation, a little bit of that overuse of the back versus the abdominals. And the brain kind of learns how to use those back muscles more often. And so that the back tightens up. People come in, they tell me my back's always tight, it always feels like it needs to pop. It's always, locked up. It feels like it's going to seize. That to me is a brain that doesn't know how to turn off the back, right? And so from a rehab perspective, we take strategies to teach people how to tilt their pelvis, how to engage their abs, how to bring their ribs down towards their front so they're not lifted in the rib cage, right? But it goes right along with kind of the breathing we were just discussing, core activation, and low back stability. Low back stability is keeping a neutral spine through your movement, and you have to accomplish that with abdominal tension.
Absolutely. Now on the coaching room call that we just had right before this, there was a great question about stretching and my thoughts on stretching and why I don't really recommend stretching for a lot of people. And you didn't mention stretching, and we have similar philosophies on stretching. Now, I would say before we jump a little deeper into this on stretching for the lower back, is that not that stretching is a bad thing, but just mindlessly stretching and the stretching for the reasons that we thought we were doing, where it's just like, okay, let me just hold this forever, or I'm about to go throw, and let me just do this, right? And there, now I'm good. Right? That the science really isn't showing that that's beneficial. And so lower back stretching, the way I learned it and the way I've coached it, is that lower back stretching is not really beneficial because, like you said in the beginning, it's why is the muscle, like the back muscles are tightening up for a reason. Like the brain is telling the back muscles, you need to tighten to stabilize that lower that spine. And it's not because and stretching can feel good for the lower back, but a lot
Right.
of times that can actually make it worse, right?
Right.
Because we're just now we're the brain is using those, telling those muscles to tighten up to stabilize your lower spine, but then we stretch and now it's all, now we're not strengthening, and then the brain's like, no, no, now you got to get a little tighter. So
Right.
jump in on that.
So yeah, tissue adapts, right? And we know tissue adapts because when we exercise, we get bigger. When we don't, we get smaller, right?
Hmm.
When we're injured, we get weaker. When we lift weights, we bulk up, right? And so tissue adaptation is huge. And when we have that kind of back on scenario, that back contraction, we get a locked short muscle, a muscle that has almost a memory of being in that short and a locked position. That memory is a neurologic thing. That memory is a proprioceptive or just body sensory awareness, positional information that it's constantly drawing on, that all of a sudden you can't just stretch that out, right? You can't just tell the brain, oh, loosen the thing that you know how to hold me up with, right?
Hmm.
You're going to have to give it something else to hold you up. And so when we're just stretching a muscle like a tight hamstring, that hamstring is probably tight for a reason, okay? When we're stretching, we're going to try and mobilize a joint. We're going to try and mobilize an area. We're going to try and kind of provide motion and prep for things. But the idea that we're just taking a rubber band stretching and then going to have a permanent or elastic change, it's coming right back, right?
Yep.
And it's coming right back for a mechanical reason. It's coming right back for a neurologic reason, a stability reason.
Yep, absolutely, absolutely. Um, and so for those of you who are watching, if you got, your back is, feeling stiff, you're wondering why you're getting the back pain, first go get it assessed, right? You say go get it assessed if you have lower back pain, but just going and jumping right into doing a bunch of lower back stretches is
Right.
probably not the thing that you need. It's the body craves stability and strength,
Right.
uh and like that's like the most important thing for the body. Like if I stand up, the only reason I'm continuing to stand up is because my tissues are turning on to keep my skeletal system from just collapsing and falling on the ground, right?
Yep.
My skeleton. So I need that stability and that strength, and especially around my joints and around my lower spine, so that if I do something, if I got to lift something, push something, pull something, that I'm not just going to collapse in the center.
Right. I think the best stretch, just to touch on that real quick, if we're talking about stretching the low back, it's just flipping that mindset. It's not about stretching, it's about deactivating, right? So if
Mm-hmm.
you have too much back pain, your back's in spasm, you're not going to stretch that, right? We're going to deactivate it. And so posterior pelvic tilts, just maybe laying on your back with your knees bent, feet flat on the floor. You take a deep breath in, deep breath out, exhale, just gently push your back against the ground. And what that's going to do is activate your abs and flatten your back, which is going to actually allow your back muscles to relax just a little bit. And that gradual kind of almost stretch of deactivation is more what's going to take pain away and tell your brain, hey, it's a safer environment because I got my abs on guard. I got my abs ready, right? So you're
Mm-hmm.
engaging your abdominals to disengage your lower back muscles. And that to me is a better stretch, right? That can actually address pain.
Yeah, I love that. I love that. And so, if, just doing that often, even if you don't have lower back pain,
Hmm.
is very beneficial. So, like, Brandon was saying, line your back. I also like to think of the cue of like lifting your tailbone just slightly off the ground. So, and brace your abs. It's going to do the same thing as with your lower back's going to press into the ground. And it's that posterior tilt that Brandon's talking about, where if your hips are like this, and think of it like a bowl. Where am I getting? Okay, think like a bowl.
Yeah.
This is my front side. If my
See if I
hips
can
are
show.
pointed forward, yeah, there you go. Show it.
Yeah,
There
yeah.
you go.
I do this all day, right? So this would be kind of that posterior pelvic tilt. We want to tuck our abs. We want to avoid overextending, right? Overextending our lower back, and we don't want to lift weight into extension. We want to have this tuck, this brace, right? And so what you imagine is that curve in the back, you kind of push your back into the ground, right? And what you're
Mm-hmm.
doing when you do that is tucking. So right here, this would be kind of the ground here or the floor. If you imagine me kind of laying down, I kind of relax, take a deep breath in, Breathe out, push my spine into the ground gently, brace with my abs, right? So you can do that standing, you can do that laying down. And Seth, as you know, that's the basis for pretty much most of our movements, right?
Yep, absolutely. And so, for everyone watching, whether it's live or on replay, you go, man, they're spending a lot of time on here,
Mm-hmm.
right? When are we going to get to the knee and the elbow? Like, we'll get
Right.
there, but
Right.
there, as you just alluded to, there's a reason why we're spending so much time here, right? Because if we are not organized properly here in the center, and we're not working optimally here with our tensioning and our breathing and our alignment here, that's going to affect the knee. If you go, well, I got knee pain. Well, first thing we look at is the hip and the ankle foot, right? But we look above and below, and when we
Right.
look at the hip, what are we thinking? Oh, is the core bracing properly? Is the lower back tight? How's the pelvis tilted? All that affects the foot. I mean, the knee, and then that affects the foot.
Yeah, I'll just really quick on that. People ask about knee injuries and this, what's the secret sauce of a knee, right? How do I fix my knee? And immediately my head is going to go to what's the positioning of the knee, right? And that's dictated by the ankle or the hip. Usually the hip is that steering wheel. Where's my camera? The steering wheel of the knee. It kind of tells the knee where it's going to live and how it walks and how it treads. And so immediately going to look at the hip, and if hip mobility is compromised, we know that core is compromised. So everything feeds into the core, and that whatever the term or the phrase I love is proximal stability for distal mobility, right? You know that.
Mm-hmm.
So, and you probably remember who that comes from, but proximal stability, what they mean is proximal meaning, more tight or central from the body. So think of like a tree trunk. You want that to be nice and stable, and then all the limbs coming off need to be somewhat mobile. They need to have some give to them. They need to have some mobility, right? So we want our hips to be mobile. We want our shoulders to be mobile, but we need our tree trunk, our core to be nice and stable, to have that proximal stability. If we don't, other things are going to have to tighten to achieve that stability, right? And it's always going to be at a sacrifice or a cost.
Yep, absolutely. I love that phrase, and it's so useful and powerful, and it made a huge impact when I first heard it many years ago. Because I sit there, I'd be working on trying to get mobility somewhere, and I'm not stable through my spine. I'm not stable and engaged here. So that we were talking about with the elbow, the shoulder, how it all affects. So
Mm-hmm.
I'm not spine aware
Right.
with with my positioning. So I'm cranking mobility and I'm like, oh, I got amazing mobility. It's like, no, you're just leaning back through your spine, man. You're
Right.
not you're
Right.
not actually
You're
getting
hyperextending.
mobility. You're just hyperextending through your
Yep.
back,
Yep. Yep.
So but awesome. All right, well, let's go to the knee. And as you just mentioned, the hip is the steering wheel for the knee. We look
Right.
at above and below, but on the most basic level, the knee is a hinge joint. It does
Right.
this really well. Sure,
Right.
in the tibia, there's some rotational movement with the foot, but not. But for what we're thinking about right now, though, it is a hinge joint. It
Right.
don't like doing this very
Nope.
well, and it doesn't like doing this very
No.
well,
No. No. No.
right?
That makes me queasy.
It threw my camera off.
Right. Yeah. Yeah.
It was so queasy. So let's talk about the knees for people who are having knee pain. Where do you
Yeah.
look first?
Well, the big injuries in the knee when the knee does get injured, we're worried about ligaments, we're worried about tears in the area, things like that. We're worried about meniscus. And when that all happens, usually the knee has lost stability, right? There's excessive mobility, there's excessive motion. One of those movements that you just showed has happened either repetitively or one time really, really hard. Obviously, trauma to the knee, football helmet goes in, that happens, right? But other knee injuries, how you slip, how you fall, and then the program that your body uses up your leg to stabilize in the moment, that's somewhat trainable. And that's knee stability and your ability to control knee movement, we'll say, during walking, during running, something like during the X step and plant and throw, right?
Mm-hmm.
Um, for just bringing up disc golf, for example, obviously we kind of plant and then we brace with that front leg, right? You can see a lot of knee injuries coming from people who put a lot of load into the front of their foot, which is loading their quad, the ACL, patellar tendon, putting a lot of torque as they're then rotating into their knee. And so just closing that kinetic chain, so to speak, or opening that kinetic chain, I should say, getting the heel rotation. That's one of the things that I do talk about, especially when you're throwing with power. Now, if you're just throwing little up shots or putter shots or things like that, you can get away with, being out on the front of your foot, especially for more accuracy. But if you're really driving in, doing that repetitively, and you're not, having some transfer of that on your heel, that knee is going to have an issue, right?
Yep.
So yeah, I think one of the other things about the knee stability, we want mobility of the ankle, we want mobility of the hip, but we don't want our knee to move like the ankle of the hip. We want our knee to be nice and stable. So when we do disc golf strong training, when we do our drills, when we do our exercise and progressions, just making sure that our knee is in its appropriate spot, that it's tracking correctly, that we're not putting excessive, load or movement or motion into that knee. That knee is supposed to be a stable joint.
Yeah, absolutely. And like I'll see people, they'll have videos, and at one time someone sent me a video and said, I got knee stuff going on. What am I doing in my technique? And I could see when they planted their foot there on their plant leg, their foot made contact, and then they rolled in, so their foot rolled in, and their knee collapsed in. So it was what we call valgus. So
Right.
like that. Right. So it was a valgus collapse, and I was like, okay, we need to work on hip stability. And they're like, oh, what drill do I need to work on in my throw? I was like, no, we need to work on hip strength, hip stability.
You need a single leg deadlift.
Yeah, because when you're planting that leg, when you're planting that foot, your muscles on the outside of your glute are not firing probably, and your knee is being directed in and dropping in, and it's getting that stress on the inside of your knee.
Exactly. Yeah. You'll see a valgus collapse. Commonly, a valgus collapse is a telltale sign of glute instability. So there are times where I'll have a patient in front of me and they're sitting knock-kneed, right? And that, to me, that's immediately a sign that even in a seated position, the glutes aren't firing, right?
Yep.
And then you go to have that same person do a squat and maybe they collapse in on the knees and they kind of round their back, right? An instant indication of glute instability that could lead to a knee injury.
Yep. So if you have knee stuff going on, do all the treatments you need for your knee, go see somebody, but also know that, we're thinking about the hip, and we're also thinking about the ankle and the foot. We're not really thinking about the knee as the root cause.
Right. And don't isolate the knee.
Yeah, absolutely. Dustin says he could listen to us talk about this all day long. Awesome. Thanks. I appreciate it. Okay. So we talked about knees. And one thing, jump in about some patellar pain, because people will reach out. They have the kneecap, the patella. They'll have pain either behind it or underneath it. Have some thoughts on that.
Yeah, great question. So we have the patella, which kind of sits in front of the tibia and the femur, right? So the femur is the leg that comes right down your thigh. Then you have your tibia comes up and makes the knee joint. So you have your tibial femoral joint, femoral tibial joint. Essentially, the kneecap acts like a fulcrum or a pivot. So the quadricep muscle coming around it has something to leverage as it lifts the lower half of the leg. So long story short, that patella, the bone, gets a lot of compression in towards the knee joint with a tight quad. And especially with a lot of flexion and extension, there's a lot of roughening or rubbing, friction of the patella on the under surface. We have a cartilaginous surface or a surface of cartilage that helps buffer that, but that can get irritated just like any cartilage. It can also get worn down in prolonged exposure or prolonged issues. And then patellar tendonitis, just like golfer's elbow, tennis elbow, Achilles tendonitis, is essentially a buildup of tension and load over time that is going to lead to the degradation, irritation, and breakdown and repair over and over and over of the actual tendon itself, which the patellar tendon is the kind of amalgamation of the 4 quad muscles coming together, enveloping the patella, and then attaching to that bone, that ridge of bone in the front of your leg. So it kind of anchors right there. A lot of load goes through that very long, big muscle, and it's having to go to a very, very kind of finite attachment point. And so we have a lot of force being translated into a small area of bone that can become very irritated either in the ligament or the bony surface. And so as a provider, if I'm looking at someone comes in with knee pain, first thing I'm going to do is make sure their glutes are firing. Same kind of thing. If their anterior chain or the front of the body is overly stressed, I need to make sure the back side of the body is pulling its weight. Or I need to get them off their toes, essentially, is an easy way to say it, which would be more on their heels, right? So when they walk, when they stride, when they run, when they push off, that might be something getting them more on their heels, which is going to be more glute-driven movements.
Yeah, yeah, absolutely. And really also the if somebody is planting on their toe and they're rotating on their toe and they're not getting they're not, transferring to the center of the foot, or the heel, or kind of blend of both, and they're just on their toes and rotating, that's going to increase the stress on the quad, increase the stress on the patella as well.
Yep. And certain quote unquote body types and genetics might be able to get away with that longer. But it's an always it depends scenario. And so it's definitely not something we can recommend. Some people might say, oh, I just do it this way and it works for me and I've never hurt myself. And there might not be anything I can say to that other than, well, you may in the future, right? But for the most part, it's not recommended, especially for power, especially for repetition, that sort of thing.
Yeah, absolutely.
And so you lose your glute. You don't have your heel to actually control, and you're just over demanding the front of your leg to do all the work.
And you don't want to lose your glute, man.
Right? Never want to lose your glutes.
There's a fun term that they say that most people have gluteal amnesia. Because their glutes are just not firing. They're the most powerful muscles in the body, right? So we need our glutes for so many reasons. Power production, hip extension, lots of things. But okay, so, and also just to kind of piggyback off that of what you were just saying, is and there's a video that inside the Performance Academy, right, that people have watched about. Don't apply a technique solution to a movement problem, right? And so kind of just, kind of segue real quick into that kind of thought pattern is if you are rotating on your toe and you're feeling a lot of stress and you're not getting to feel like you're getting the power and the bracing and all that, you're not, the results are not what you want them to be. It could be a technique solution, but first let's do a movement. It might be a movement problem. Why are you going onto that toe? Probably because the glute doesn't know how to stabilize and fire. So the brain says, okay, strategy is to go to the toe, because if I go on the heel or the midfoot to the heel, I don't know what I'm doing there. I don't feel stable. I don't feel strong. I feel better on my toe. And so let's not apply a technique solution to a movement problem. Let's fix the movement first to get that glute firing. Let's learn how to absorb force in that position on that stable leg. And that might be, that's the first step.
Let's take that, just on a real quick scenario. Say we told that person who's having knee pain, hey, just fix this, go on your heel, right? But they don't have the prerequisite hardware to do that, right? So we're trying to, like you're saying, apply a technique solution to something where the brain still can't compute. It still doesn't know, okay, well, now you're on the heel, but who cares, right? There's nothing there to talk to, right? So the whole stability part is to give it something to talk to. It's the stability, what is stability? It's that foundation, it's that support, right? It needs fibers of muscle to talk to draw on, to be able to fire and enact in an instant. And if they're not there and that pattern isn't, pre-prescribed and pre-written, that technique fix, that little tip, that little thing isn't going to really be learned. It's never really going to sink in. It's never going to be layered into the proper technique, we'll say.
Yeah, absolutely. And, I can sit there and I can write down on paper. I can say it as many times as I want. I can sing it in the shower that I want to be able to throw 450, but my brain's not gonna be like, oh, you want to throw 450? Okay, let's do it. No,
Right.
like it's like
Yeah.
it has to feel strong and stable and powerful and comfortable to release those internal parking brakes to allow you to access more of that power.
It's funny because, you think mind over matter, but it's almost the less you try, the better it gets.
Yeah, exactly.
Right.
Exactly. Awesome. All right, let's go up the body.
Hmm.
Let's go to the shoulder. All
Sure.
right. Now, before we get into the actual shoulder joint, which we want to jump in there, we're gonna first go a little behind to the shoulder blade, the scapula. Right. So let's talk a little bit about the scapula. A lot of people, most people that I've ever dealt with, worked with and seen, they their scapulas are not functioning like they should. There's different terms, scapular dyskinesis. There are a lot of different things you can do, but
Mhm.
say about it. But our scapula needs to be able to move up and down. It needs to
Yep.
move side to side on the back. It tilts here. It rotates upward. It rotates down. Right, and it's really if it's not stable, if it's not moving well, and if two, it's not stable and strong, then it's going to affect everything else. And if it's out of position, right?
Right.
So if I hold my scapula, if I press down here and I don't allow my scapula, my shoulder blade to rotate up, I
Right.
can go here. I can go about 90 degrees, right? Parallel with
Right.
the ground. And then I can't go any more above that. I have to let my shoulder blade rotate so that this joint goes and allows me to go
Right.
up, right? So let's get into the scapula just a little bit.
Sure. So the scapula, as a bone, shoulder blade, it absolutely needs to have mobility. If your scapular shoulder blade is fixated and you have the ball socket trying to move with it and it's not moving with it, you're going to get abutment of basically bones coming together. You're going to get impingement. You're going to get popping, clicking, snapping, tendon irritation, things like that, right? And so,
Mm-hmm.
I have a lot of, try and get my shoulder on view. So I have a lot of success just in what I was showing before. It's so important just coaching people that your shoulder shouldn't be moving from this rounded position. You shouldn't be elevating with your shoulder rounded forward. That needs to happen. Sorry, I'm having trouble showing that, with your shoulder brought
Oh,
back, right? So from this position is where we elevate, where we pull, where we kind of either, have our reach back. That reach back is dependent on your shoulder blade getting out of its own way, right? Someone who doesn't have shoulder mobility, you see they round, they kind of turn across themselves. That shoulder mobility is your ability to kind of actually fully reach back and actually get your shoulder blade out of its own way for that shoulder mobility so you can actually kind of tuck in and load coming through, right? So not necessarily talking technique, but more so it's the prerequisite to be able to do proper technique, right? It's the
mm-hmm.
hardware problem to the software solution, so to speak, or
Yep.
vice versa. I don't know if I said
Yeah,
that
yeah,
right.
yeah, 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 yeah,
Yeah,
absolutely. So working on the getting your shoulder blade to move better. So for everyone following the program, you go, oh, we're doing floor slides. What are floor
right,
slides for?
right.
They are helping your shoulder blades
Yeah,
learn your scapula how to upwardly rotate, how to go back, right? Because so many people that have stuff going on with their shoulder, it could have an underlying cause of the shoulder blade. They have a wing scapula too, is a
yeah,
big thing,
yeah.
right? So I've had people where they go like this, they go, oh man, I get a lot of pain when I get to this level, right?
Right.
I raise my arm here and then I have pain,
Mm-hmm.
right? And then I will take my finger and I will put it on the inside edge of their shoulder blade near their spine. And I will say, okay, lift your arm up over your head and I will push the shoulder blade
Mm-hmm.
out and they'll be like, I have no pain.
Right,
I have no pain
right.
when I'm doing that, right? They go, yeah, because your shoulder blade is stuck down
Yep.
and you're trying to lift it. And like you said, it's going, uh,
Jamming into it.
uh.
Yep, yep.
It's just
So,
jamming it.
yep. So you're allowing them to reduce impingement essentially and giving them a little bit of that shoulder mobility because the shoulder blade, the scapula, actually houses kind of the meat and potatoes of the shoulder joint. it creates the socket that the ball actually fits in. So that socket actually has to give a little bit. And if it doesn't, because the shoulder has such excessive range of motion, I mean, we can go 180 degrees, 180 degrees. We can come forward all the way, backwards all the way. There's no other joint in the body that really does that, right?
Yep.
And so that shoulder blade and arm relationship is super important. You know, when you see the best athletes throw and they're having that reach back, right? That shoulder blade is actually coming away from the spine and then pulling back into the spine to engage stability, right? And so that stability is actually coming from shoulder blade activation and activity. It's not a ton of motion, but it's definitely there.
Yep, absolutely. So for those that are thinking, oh, I need more shoulder mobility, that's probably not it. The shoulder is the most mobile joint in the body. Now, could there be a reason that you need to work on? You have restrictions in your shoulder capsule. That could, but that's working with somebody like Dr. Branden and go in there can actually assess that. For most people, working on shoulder stability, working on scapular movement. So those floor slides we're doing. Also, for those when you're doing those exercises during week 1 and you're going up overhead, you're lying on your back and you're doing, we call it supine. So lying up, right, face up, and you're bringing your arm overhead, the overhead flexion. Your shoulder blade is rolling down and back. Everyone at home that's watching this, even if you're watching a replay, okay, I want you to slouch forward. Okay, so like you're at a computer or on your phone, right? And then try to lift your arm up overhead. Like try to lift your arm up.
I heard a crunch too.
Yeah, right. Okay. Yeah. I know a good person to go and see about that. So here and now, sit up nice and tall. Slight brace in your abs. Keep your ribs down, pulled down a little bit, and lift up overhead. Right, and you should feel like your shoulder blade is rolling down the back of your torso, and you're trying to like almost tuck your shoulder blade into your bottom, like opposite back pocket. Right. So there. Now that's giving me mobility, but also, like you said, we need stability, because there's a great analogy that I love is if our shoulder doesn't know how to stabilize and our shoulder blade doesn't know how to stabilize, especially when we're throwing, that's like trying to fire a cannon off of a canoe, right? You're gonna be able to do it, but you're gonna lose power. You're gonna not have good consistency. You're not gonna have good accuracy. You're not gonna have the results you want.
It's a great analogy because, okay, let's think about what's really happening. And when that cannon fires, well, that's a rotator cuff strain, right? That wobble of the canoe, well, that's your rotator cuff tendons, right? Well, that's your upper trapper neck muscle that's going to take the brunt of that, right? That's your lat that might take the brunt of that, right? So, when we're saying, yeah, it's all, all these cliches and analogies, they help us understand things and help us communicate these things. But realistically, that's the injury we're talking about. That wobble of the canoe is the instability in the shoulder that's going to mess up soft tissue in that area.
Yeah, absolutely. All right, so before we go to the actual shoulder joint, let's back it up a little bit. Let's go more towards the midline and hit that thoracic spine.
Sure. So, one of the things that we kind of touched upon this a little bit, but let's just walk people through the ground up mobility, stability. So
Perfect.
Ankles mobile, knees stable. We already touched upon that. Hips, we kind of need a mobility, stability, because life happens on one leg, really. You're walking on one leg, the other leg needs to swing. So there's this stability and mobility pattern, right? But as you come up, we want the trunk and the core to be stable. We don't need excessive motion in the low back. But what does that mean? We need movement out of the thoracic spine, your middle back. And so many people have that either, sedentary job or a little bit of a postural issue or just tightness, whatever it is, right? Even, mental health, anxiety, stress, all kind of plays into that. So things that I address with my patients. But long story short, we need mobility in that thoracic spine. And I'm not just going to say thoracic spine, I'm going to say thoracic spine and rib cage, right? We need a rib cage to move. We need that to expand and contract with breathing. We don't need any sort of restriction in that middle back because we already have our stability in our trunk.
Yep, absolutely. And so we need that what we call, right? We're stuck in So for you watching at home, we get stuck in this flexion pattern. So flexion for our upper spine. So our thoracic spine is our upper back, okay, our
Hmm.
T spine. So we're flexed forward all the time. So we need to be really working on a lot of extension. So going from here to here, right? And
Right,
then not just extension, but extension and also rotation. So
right,
when you're doing your exercises in the Performance Academy, and we're working on that thoracic rotational mobility, because we want to get that thoracic spine from the upper back and also from the hips, not from the core. Like Branden was saying, there's a alternating pattern of stability and mobility through our joints. And so we need stability through the spine, through the lower spine, mobility through the upper
right,
spine.
right.
And that's flexion,
Right.
extension, and rotation.
Right. So when you're saying flexion, extension, rotation, I'm just going to really quick just touch upon, because this is one of my things, right? We're not talking
Perfect.
of the low back. We're talking
Mm-hmm.
only of the middle back. And the only way you're going to accomplish that is by having a nice braced core, right? And so
Mm-hmm.
I'll see if I can just demonstrate, right? So we're not talking about flexing and extending from the back. We're talking about keeping this straight and braced, and then flexing above that. So this is staying locked. This is what's rotating, not the lower rotating, right? So we're
Yep.
talking about that upper back. So those heel sit T-spine rotations, like you mentioned, I use those in practice. You know, I adopted those from you, and I use those as a warm up. I use those for my desk workers. I use those for you know, people learning breathing and just kind of getting them opening up. But it's such a great thoracic spine and breathing engagement.
Yeah, absolutely. And it's something we need to do often, right?
Hmm.
One session is not going to cut it, but one session is better than zero sessions. But
Right,
so working on your mobility all the time, right? Even if you're sitting at a desk all day and you're sitting like this, you want to try to be working on your posture, but spend time where you like stand, even if you stand up and stand up tall, like imagine you're standing up like you're a soldier and you're, like a Roman soldier or something. You're standing up nice and tall and strong. You can flex forward and then roll the shoulders back, feel that extension, feel that nice tall
yep.
extension through your spine, and then come back and up. And then you can rotate, like you said, brace that core,
Hmm.
rotate. Again, what does that go to? That goes to I think a lot about that quote, right? Of don't apply a technique solution to a movement problem. And that the thoracic spine is one of those areas where
Yep.
people are like, oh,
Yep.
I need a deep, I can't, I don't feel like I can get a lot of my reach back. Like I want a deeper
Right.
reach back. Like, what do I need to do? It's probably your thoracic spine
Get a
is not
lacrosse
able to
ball.
rotate. Yeah, exactly. Yeah, do some commando rocking, do some,
Yep.
do some extension over a foam roller, or,
Right.
some, a lacrosse ball is like a peanut or something, right? And that is going to be better for you because you're going to be able to actually improve that mobility. And now you're like, wow, okay, I
Yep.
can get more mobility here. I'm locking things down in this core, and I'm able to rotate through here. I'm not having to try to use all these different drills. Those that like skill drills, that's like up here. Down here is like good quality movement. We got to attack here first before we attack up there.
You need the hardware to put the software on, right? You know, if you don't have enough RAM and you try and get the latest game, who cares?
Yep, absolutely, absolutely. So for everyone, thanks again for tuning in. We're gonna go down to we're gonna go to the shoulder and then the elbow, and then we're gonna take some of your questions, or all of your questions. Anyone who left a question. So if you're watching this and you still want to ask something, please don't hesitate to ask it. All right. So we talked about the shoulder. Now we're going. We talked about the shoulder blade. Now let's go to the shoulder.
Cool. So, you know, in the shoulder, and the shoulder blade itself houses the rotator cuff. And so the rotator cuff kind of crosses, let's see where my hand is. It's always backwards on camera, right? So the rotator cuff crosses over the shoulder and gives us motions like elevation, external rotation, internal rotation. And those muscles aren't the biggest muscles. So they shouldn't be our primary stabilizing muscles, right? That stability actually needs to come from the shoulder blade. And then the rotator cuff kind of synergistically or teamwork wise works together, those four muscles, to control movement, to accelerate, decelerate, to traction the ball joint, to keep stability in a sense through mobility. But it's not supposed to be the primary stabilizer. If we ask those smaller muscles to primarily stabilize and tighten and move, there's going to be a conflict essentially. So when we're talking about the actual shoulder, most people know the rotator cuff, CUFF. Sometimes I hear cup or rotor cuff, something like that, but it's rotator cuff. And it's four muscles, and sometimes they call them the SITS muscles, SITS. So it's supraspinatus, infraspinatus, teres minor, and subscapularis, which really just fancy words, but when you know where they live and you know kind of how they pull and how they operate the shoulder, the words don't really matter. You just kind of go to how the shoulder functions, right? In isolation, you can strain those muscles, so you can tweak them. It's always possible if you kind of lift something overhead and your shoulder's out of position, boom, that's a little bit of a rotator cuff strain or sprain. But what we're trying to avoid is long-term wear and tear, right? And that's going to come from proper positioning of the shoulder. Also, honestly, limiting repetition in a certain sense. So if we're starting to get sore, we're not pushing through and just kind of overloading and throwing another 100 throws, hyperbole maybe. But yeah, when it comes to the shoulder, it is a mobile joint. We need to protect it in a sense that it still needs the stability of the scapula. Rotator cuff is kind of the big focus, but also your bicep tendon. So right in the front, anterior bicipital issues can always happen when the shoulder's rounded. So again, I'll just come back to this position. So our bicep doesn't want to be kind of closed off. And as soon as we round our shoulder, our bicep has to kind of reroute and come inside the shoulder, and that tendon ends up snapping over the groove that it lives in, the bicipital groove. And so, anterior shoulder pain, as soon as I hear that, I'm going to be thinking biceps, postural or positional issues with the shoulder. And so again, a lot of this conversation, why we started core, why we started talking about the rib cage and breathing, why we talk about thoracic mobility, that all plays into what I see in a shoulder. The shoulder is really just the tip of the whip, but where that movement came from, that came from the handle, right?
Yep. Absolutely. And so as you were talking about the bicipital, tendon and all that, and people will have, they'll have shoulder pain here, right? They'll say, oh, it hurts right here. So if they were to do this and this, they go, oh yeah, that don't feel good, right? A lot of times it's right. We're not diagnosing anybody right now, but usually it's an impingement here, right? And we've already been talking about that the shoulder is the most, this part of the shoulder is the most mobile joint in the body. But it's also, there's not a lot of space in between here. Think of it as a golf ball and a tee, right? And there's not a lot of space between here and here. So if this is moving around, we have to get what we call joint centration. Okay. And now we're not going to go too deep in for all of you on here. I know we're going to try to keep it, not getting too nerdy into the science, but
we can do this all day.
Yeah, it's all right. So we want centration in this joint. Okay. So that's why we're strengthening our muscles. We're doing rotator. We're strengthening the rotator cuff muscles, because that's really one of their main jobs, is to keep that shoulder joint perfectly in there. So as we're moving, and as this moves, that this stays right in the center. Now, when we have issues is when this starts to get out of center, right?
Starts to
where's the camera?
Other things, right? It starts to pinch tendons, it starts to create an impingement syndrome, and that's where you get your rotator cuff tendinopathies or tendinitis. That's where you get your torn ligaments or tendons, things like that. And even an AC joint. The AC joint, I'm sure everyone's heard, football, sports injuries. Yep, that's your acromioclavicular joint. So it's part of your collarbone, meeting your acromion process, which is actually, again, part of your shoulder blade. So why that shoulder blade positioning and mobility matters is your AC joint is dependent on that compliance.
Yep. Yeah, exactly. And so let's think, right? I get a lot of people will say, hey, so I feel pain in the front of my shoulder when I'm throwing across my body or
Mhm.
when I'm putting,
Sure,
right?
sure.
So so for everyone at home thinking, what we've been talking about is if you are in a flexed forward position all the time, you don't have, your posture is not ideal, it's not optimal, right? And your shoulder blade's not moving like it should. Well, if I go to putt and I'm rolled forward,
Yep,
what am I doing? I'm doing this. So this is the front. Yeah, this is the front, and I'm doing this.
yep,
Mm,
yep.
mm,
Yeah,
right?
basically, if you
I'm
told me,
pinching.
if you showed me you're putting with a rounded forward shoulder at the end of your throw, I would say I'm not surprised you have pain, right?
Exactly.
I'm not necessarily diagnosing technique. I'm not saying you're doing it wrong, but in that, yeah, it makes sense because you're jamming part of the tissue and you're not getting out of your own way, so to speak, right? That the natural motion of the shoulder is kind of hitting its wall. And just that motion, I know that your shoulder blade's kind of falling off the cliff, the bicipital tendon's getting impinged. That shoulder joint, as you demonstrated before, has a limited amount of flexion that it can achieve. And so we can't go through, like someone like Johnny McRae, I think of how fluid his follow through is, how much follow through he has. He can't do that with a forward rounded shoulder. Let's put it that way.
Mm-hmm. Yeah, exactly, absolutely. And if you're rolled forward, rolled shoulder, and now you're bringing across your body,
Yeah,
now you're not just doing this, you're going, "Ah,"
yeah,
and you're,
yeah, yeah.
and you got your tissues in between there, and they're getting pinched. And then not only once now they get pinched, now they get inflamed, right? Or they now they're super sensitive and now they're gonna get feel like they're getting pinched all the time now, right? And
Mhm.
then they could eventually get frayed and stuff. So this is why we get into this. Now, another thing to talk about with the shoulder is anterior instability. So what I mean by that is we say, when we say anterior, we mean the front. Okay. Now the joint, like I say, it's just sitting in there. It can move around. I mean, it can pop out. You know, it's hard to do that, but I'm just saying, like, it's not locked in there like this,
Mhm.
right? So we go to throw backhand, and now here, and my arm is going back like
Mhm.
that, right here, that wants to pop out of the front.
Yeah,
And so these tissues right here, they're hanging on for dear life
yeah,
to try to keep that joint, the integrity of that joint, right?
yeah,
And same thing. So they have found, so when we're throwing forehand too, and our torso, we're rotating forward and our arm is still back, we can get pinching actually back here. We call like an internal impingement, right? Uh,
mhm,
posterior impingement. But
mhm,
here, this I'm rotating forward. My torso is rotating. My arm is still back behind me. This is anterior, and this can stretch the tissues in there,
yep,
which means that can be unstable, right?
yep,
And so they find in baseball pitchers a lot of anterior instability because of that position. So that's when we're doing shoulder taps, when we're doing all our shoulder stability exercises, we're trying to make sure that this shoulder joint is is stable and strong. And so people go, well, hey, shoulder, why aren't we doing shoulder presses for a strong shoulder? That's not what we're, that's more anterior. That's, getting
right,
nice, huge, strong, big delts. That's not really shoulder
right,
stability for throwing.
right, exactly. No, I agree completely. I think when it comes to shoulder health, I think there are a lot of not myths or misconceptions, but I think, in alluding to the CFSC and why I chose that program, but the fitness industry has had a lot of kind of stuck in its ways, as I know
Mm-hmm.
and I'm starting to learn. But a lot of people do things because that's the way it's done, or that's the way they were taught to work out, or they played football growing up and that's what they did in the weight room, so they know Olympic lifts and presses and stuff like that. But these functional movements that we're doing is much, much more how your body actually operates, right? And then also not just putting weight on top of dysfunction. We have to make sure before you do a press that you earn it, that you have that scapular stability and that shoulder mobility to actually put that weight overhead and control it without your brain using a strategy of compensation or back arcing or something that's going to lead to dysfunction and injury, essentially.
Yeah.
Yep.
Absolutely, and I'm glad, thank you for bringing that up about the personal training industry. We were actually talking about this on the coaching room call tonight, and I'm not trying to call out the industry, but I kind of have to a little bit because really with personal training, you don't have to be certified to call yourself a personal trainer and work with people. You can, I remember years ago, someone as a joke, they got their dog to be certified as a personal trainer. And I, as a personal trainer, but really more as thinking of myself as a strength and conditioning coach or performance coach. I go, we had a good laugh about that, but then we kind of like did a little bit of that as well because someone can get a 1-day certification and have no other background in rehab, like or like your level of education or my level of education, a degree and the the internships and things I did, where you can go on and you can see the videos they're posting on Instagram or Facebook or YouTube, and you're like, why aren't we doing that in Disc Golf Strong? They shouldn't even be doing that. They're moving for movement's sake and trying to get likes and and thumbs up and hearts and stuff. So you can see people go, oh, do this shoulder stuff, and they're like, oh, and they're like, they're not thinking about integrity of their core, their torso, nothing.
So if you think about what we talked about so far, and you think about not putting weight on dysfunction, most people know, that's something that I'm not really good at, or I'm not that strong at. So then why would we just load that pattern only and just do that over and over and over because we saw it on Instagram or because that's how I know how to get big, right? Even though it might seem either less effective because there isn't weight or whatever, what we're doing and what you're doing with Disc Golf Strong and showing everyone is so much more impactful, because this is how your brain is actually going to learn movement. This is what you're going to be able to put and actually build levels of the house on top of, instead of trying to build the roof before you have a foundation.
Yep. As a coach, I could actually get a lot more people watching my stuff if I was just trying to do things that made people sweat and get their heart rate up and go crazy and things like that, right? But what I love about working with you as well, and I know I feel like you would say the same for me, hopefully, is and why we have this program and why we're having these talks and stuff is that I think of it as my role with my athletes, and also with my athletes in the performance academy, my athletes on tour, things like that. I think of myself as a coach, kind of like a commercial airline pilot, right? A commercial airline pilot can go to an acrobatic air show and watch acrobatic pilots fly upside down and stall in midair and do all these crazy things, but they would never do that in their own plane, right? Because their job is to get their passengers from point A to point B safely, and everyone collapsed, not because the plane flew upside down, but because they hit as little turbulence as possible and it was a nice, smooth, soft landing, right? And so I see things online, I'm like, oh, like I would never ever do that with my athletes or any of my clients or recommend it. Sure, it looks cool to see someone jump up and do that crazy stuff, but for the general person that I'm working with that wants to be, and I know that you are the same, right? Like, would we get more people liking our stuff? Maybe if we threw something on there that was just super crazy and for all the hearts, but that's not what we're about. And so, that's, we'll get back into the injuries, but I just wanted to, again, thank you and kind of dive into that a little bit about.
Just because it doesn't look necessarily disc golf specific doesn't mean it's not going to translate right to your disc golf game. And we alluded a little bit, not to oversell the program I'm doing or the Mike Boyle stuff, but Mike Boyle is one of the best strength and conditioning, well-respected strength and conditioning coaches. He trained with the Red Sox when they won the championship, the Bruins. He trains with, I think, Boston University. So he has athletes of every sport going in, and they're doing very, very similar protocols to what we're doing in Disc Golf Strong, right? Single leg deadlifts, dead bugs, functional core strength, working single leg balance, proprioception, shoulder stability, all the prerequisites of movement. And the prerequisites of something like the Performance Academy that's giving you the step-by-step basis and layering those foundations to really make it a sustainable type thing. It's not a fad. This isn't something that we're that Seth's looking at just to be a come and go thing. This is layering that foundation, right? So he's making you the best disc golfer, an injury resilient disc golfer that you can be. So yeah, absolutely. I'm with you.
We're trying to make you all performance race cars, but we're starting with the engine, and we're starting with the foundation first, and then going out. Right? We're not wondering what kind of steering wheel color we should have or this and that. Like it builds out.
Lap time the first lap out. You know, you got to run the track a little bit. You got to tune the machine a little bit. You got to bring it back to the pit. You got to, a little more air in this tire. Well, now I know the route a little bit, so I'm a little more confident, right? How about that?
Yep.
Just getting the confidence in your movement, getting the mental preparation after you do 10 laps, right? Same kind of thing. And so this is everything that Seth is bringing you guys, and everything that we're talking about here today is meant to give you that hardware, so that way you can load the software, the technique on top of it.
Yeah, absolutely. No, absolutely. Okay, so we talked about the shoulder, and one quick thing for people that are watching that they want to strengthen their shoulder. You're doing the right things. You're doing the shoulder taps. You're doing the stability work, right? Yep. People wonder, okay, what about like band work, like rotate, the rotator cuff stuff. Now,
Yep.
At one point I was for it years and years ago when I didn't really know anything, and then when I felt like I learned a lot, I was totally against it. Now, because they, the rotator cuff muscles, they do this. But they found out kind of like on cadavers, like, oh, what does that muscle do? Oh, okay, it must rotate this, right? But that's not what they're designed. They're designed to pull the shoulder into the socket and hold it, and then stabilize it as it rotates. And they do help rotate. So can you do a band here and do this? Yes. But what I don't like about this is people will just grab a band and they'll go right, and they'll just, it's not locking everything down, breath, right here, or integrating it with a row to this, right?
Yeah, what I was going to say, yeah, exactly. Setting that scapular stability first and then putting the movement on top of it, right? So, and especially with the shoulder, if you're not using the core, you're not working the shoulder, because you're basically putting a muscle in isolation, and that is not how the shoulder is going to be used when you go to call on it, right? We need that reflexive stability in the core first. You better be in a good position with those shoulder blades and rib cage, and then we can press, and then we can pull, then we can lift and elevate, and kind of train in that isolation. But you better be breathing, you better be activating the core first, right? And if we're not, if we're just thinking, I forget, it was Rachel Balkovich, she's the strength coach for the Yankees. She talked about arm care, and how she's trying to flip the script of arm care and not call arm care, that we're doing ourselves a disservice by just compartmentalizing that it's full body. You better care for the full body if you're going to care for the arm. And same thing goes with the shoulder. So think of your core work with your shoulder work always. Think of your core positioning with your shoulder work always. And when you train and exercise and you say, well, is this good or is this strengthening? If your core is not engaged, you're not posterior pelvic tilting, if you're not setting that shoulder blade, chances are we're strengthening in dysfunction.
Yep, absolutely. All right, we're going to go to the elbow. We could probably spend, 2 days, 3 days, talk about all this stuff and getting super in depth. Thank you everyone for continuing to, listen, and we definitely look forward to getting your questions. We're going to finish out with the elbow. And then after, in the future, you got any other more specific questions, you can always feel free to post it inside the academy or ask us, right? Okay, so going down to the elbow, I heard it explained by Eric Cressy, who is like the #1 strength and conditioning coach in baseball for pitcher, like strength coach in baseball. He's with the Yankees now, but he's got 2 huge facilities. His facilities manage over $1 billion in Major League Arms. And I went to a seminar, have all his stuff, and I was hanging out talking to him a couple years ago in Colorado. We were talking about the elbow, and I've heard him say this before, is that the elbow is like the most claustrophobic joint in the body, because it's such a small little area. I mean, there's so much going on inside the elbow, right? Before we get into what's going on inside the elbow, I want to say this first. We weren't designed, our bodies were not designed to throw forehands, sidearms, flicks, right? And this is going to be controversial, but it's just reality. I'm
Mhm.
not saying, when I say this, I'm not saying that we shouldn't throw forehands or flicks or sidearms, wherever you call it, wherever you're at in the world, right? But like our legs, if we run, like our legs are powerhouses, like they're designed to do that movement, right? Our
Mhm.
elbow is not designed to handle the types of stresses that we put on it in the forehand, right?
Right, right,
Now that's, like I said, that doesn't mean that we can't do it, but we need
right.
to be able to condition ourselves and also understand that there is a high injury risk when we do that. Like baseball pitchers, they've been training, conditioning their elbow, their arm, their shoulder since they were kids, and they still have elbow issues
Right,
going on, right?
right.
So we'll dive into this now. But
So
all right.
yeah, it's funny because if you, so say you take Eagle, right? You take his technique and you freeze frame right at that moment where his arm's whipping back and it looks crazy and you're like, how does he do that? And how does he even, accomplish that? And then people go out to the field and they're trying to whip their arm and get their arm to kind of do that thing. Well, Eagles learned how to stack that motion to keep his elbow tight, to then get his elbow next to him and then push his arm through. He's not necessarily just putting everything into the elbow and whipping, if that makes sense, right?
Mm-hmm.
And so when we talk about what the elbow is designed to do, it's almost like the knee. It's not really made for excessive movement. It's supposed to be kind of the stable joint in between mobile wrist, mobile shoulder. This isn't supposed to be going back and forth. It shouldn't be doing all sorts of stuff. So when we do a forehand and we're coming in trying to load and doing something that's really leading with the elbow and torquing this inner part of the elbow, which is where we get so Tommy John surgery essentially is the correction for the injury of that ligament. It can create ligamentous stress. It can create instability at the elbow. It can create either short-term or long-term kind of damage. And so when we look at forehand technique, so to speak, it's not just an arm whipping kind of thing. And it's not like there's one right way, but there are wrong ways, so to speak.
Mm-hmm. Absolutely. And so like you're talking about too, many people have heard of Tommy John surgery, and that's it. There's a ligament here, the UCL, the ulnar collateral ligament, and that's one of the ligaments here that helps provide stability for here. So I
Mhm.
like to think of it this way too, is explain it this way. This stress, this is called a valgus stress, and the elbow does not like to does not handle that stress well as it handles other stresses, right? Think if
Yeah.
you were to, so to explain valgus stress to you, to not to you, Brandon, but to everyone watching at home. So if you were to stand up and you were stand up and you were to jump up and then you were to land and keep your feet underneath your hips, but let your knees, knock together, and then jump back up and let your knees slam together and jump back up, even if they don't slam together, just that action of your knees like caving in towards each other, that's a valgus stress on that
Yeah.
knee joint. Okay.
Yeah.
Now, you don't have to be a fitness professional to see somebody landing like that and go, that don't look healthy,
Right.
right?
Right.
So if we were to look at somebody landing like that and letting their knees just drop in every time, anybody would be like,
Right. Right.
ouch, right? That is the stress that is going on in that elbow joint. It
Yep.
is a valgus stress in that elbow.
And someone like Eagle is probably an interesting example because he's probably somewhat hypermobile. He has a little bit, genetically, his tissue just has a little more flexibility to it. So not everyone's going to have that same capacity or capability to load and stress their elbow to that kind of failure tolerance, if that makes sense. And the other thing is he's built up that tissue tolerance. He's built up that load capacity. So that's something that, again, comes from just solid ground up form, and not just asking too much of just the elbow. It's the shoulder, it's the core, it's the elbow, it's smooth transfer of motion. If it's just that elbow taking the brunt of the motion, think of the knee, right? It's not supposed to be super mobile. We don't want wobbly knees. We don't want wobbly elbows.
Yep, absolutely. And even Eagle has been public about this, that he's had, elbow issues and shoulder
Right.
issues. And I know Eagle's one of my athletes. And so uh, over the years, like, last year, 2 years ago, him and I were having conversations when he was having elbow issues and shoulder issues and things, where I was like, just because a pitcher a baseball pitcher can hit 100 on the radar gun doesn't mean that they just pick up a baseball and try to hit 100
Right.
anytime they feel like it, right? Like they have to make sure they're ready for it, conditioned for it, and also they're not throwing 100 every single day,
Right.
right? So Eagle calls these forehands spicy for his spicy forehands,
Yeah.
and he has had to now think about game management and body management,
Yep.
where he thinks, okay, I like the forehand here. Should I throw the forehand here because I have to think about what's going on here too, right? So he will limit his spicy forehands, especially in practice. But we are doing things where he's doing things like this, where he's trying to get his shoulder and his elbow, or like the tissues engaged and fired up before he throws his forehands, especially his big ones. But knowing that he shouldn't just go out there and just do it whenever he feels like it, um, and not expect and not understand that there are risks involved with those big forehands. And going to the baseball world, right? I talk about pitchers a lot when I'm working with when talking to my athletes and explaining about the elbow, and say that they've been doing that, like you said, Eagle, been doing that for like almost his whole life,
Right.
right? Where we will sit there and we'll watch a clinic online or visit a clinic, or we'll be like, oh, I want to get in my forehands.
Right.
What do we do? What's everyone do? Grab a disc and try to throw as hard as they can. They're going for distance right away, right? And so they're not working on making sure that they're conditioning and building up that tissue tolerance. And so for everyone that's watching, so what we're trying to do really when we're getting stronger, one of the things we're trying to create a buffer zone. So if our tissues can only tolerate this level of stress, right? But we are applying stress up at this level, right? That is like an injury zone right there. We are putting more stress, either acute or chronically, on top of tissue that can only handle this much tolerance stress, right? So when we get stronger, we're trying to increase the tolerance, like Branden said, the tolerance of those tissues to be able to withstand more stress. So then we're going here either acutely or chronically. This is the stress we're applying, and we're trying to create a buffer zone here of strength and tolerance so that we're here, right? We're not
Right.
applying this amount of stress and our tissues can only handle this much tolerance, right? We're trying to get that buffer zone. So that's a big part too.
Definitely. Yeah. With tissue tolerance, it's why we train. It's why we obviously go to the course and play, but we can't expect to and it's interesting because that's where you go back to the whole technique solution movement problem, right? You want to incorporate these little tips and things and technique things and things that the pros show you and tell you and things your buddies tell you, but also realize that to actually learn that, to actually get better at that, that's going to take putting it into practice with the right foundation, and that's the way your brain's actually going to learn how to incorporate all these muscle groups together in the way that they're supposed to, so they're not resisting themselves, so they're not fighting themselves, they're not compensating. I know I'm speaking in generalities, but yeah, so it's funny because with the forehand, you'll get people that only throw forehand, right? Oh, I only throw forehand, right? And I think about what that looks like, and you see them just like over flexing or mashing an overstable disc and getting that full flex flight out, and yeah, you're getting it done, but the repeatability of that, the sustainability of that's rough on an elbow, on a shoulder, those types of things. So when we say there's no right way but there's a wrong way, that's kind of what I'm alluding to. There are definitely things that I can see out of players where I'm like, yeah, that's probably going to hurt something.
Yeah, and a big thing too is managing. If you want, okay, so if you want to lower your risk of getting injured, this is coming from a coach. Okay, I'm
Mm-hmm.
just do a little coach talk here. Manage your expectations
Mm-hmm.
and follow the process, right? If I go out and start throwing a football and I'm like, oh, hey, it's fun to throw a football. I feel like I can throw a football pretty well right now as I'm throwing it to, my brother or my wife or something. I'm like, oh, maybe I should go on and online and watch a clinic from Tom Brady on how to throw a Hail Mary, right? Because he can throw a Hail Mary, and or I'm watching Brett Favre's technique on his Hail Mary, when that big game years ago, and now I'm trying to throw Hail Mary when I literally just started throwing a football, like 6 weeks ago, 6 months ago, even, right
Mm-hmm.
there.
Mm-hmm.
If I'm trying to hit that, I have to manage my expectations and realize where I'm at. And that's part of injury prevention. And that's part of good game management too, of knowing that, okay, I'd like to do that, but where I'm at right now, this is what I should be focusing on, not what Eagle can do, not what Sexton can do with a forehand, right? Or Ricky, but what I can do with a forehand, right?
Mm-hmm.
And not try to throw like Sarah or anything like that. Manage where you're at right now, because when people jump in and they start trying to do what these pros that have been doing this for a long time, who also battle injuries
Mm-hmm.
with their shoulders and their elbows, right?
Yep.
Uh, that you're gonna move much faster into that risk category of injuring yourself, right? Um,
Right.
and we talk about this a lot, right? And I talk about this all the time, is pitch count, right? Volume. Um, One, you got to get strong. You got to strengthen all this, starting here. But then you got to strengthen everything. You got to strengthen these tissues, and good tissue quality. But a big thing is volume. I just wrote an article for a company yesterday, or a couple days ago, 2 days ago or so, that just came out talking about volume and pitch count. It's UDisc, and they I was telling them about, one time I was at a clinic and a guy came up and said, "Hey, you know, I'm a really good, I have a really high rating, and I am right there at the top, but I have so many issues with my elbow. My elbow is always killing me. Um, but I hit the gym all the time. I'm doing, like cleans, and I'm doing, bench press and this and that. Like, what's going on? Why is my elbow?" And I was like, "Well, how much do you throw?" And he's like, "Oh, I throw like 5, 6 days a week. Uh, you know, hour sessions, 90 minutes on the field work, plus playing rounds, throwing a
Mm-hmm.
ton of forehands." I'm like, first off, you have a volume issue
Mm-hmm.
more than you have
Mm-hmm.
anything else,
Yep.
right?
Got to
You're
recover.
putting you're putting so much volume on that elbow. Uh, you go to talk to a professional baseball pitcher and say, "Hey, can you throw this bucket of 100 balls every single day as hard as you can?" They would be like, "You're
Yep.
crazy, right? You're
Yep.
crazy, right?" Why would
Yeah,
they say
well,
you're
they have
crazy?
a
Because they
bullpen for a reason, right? They warm up, they get loose, they go through their arm drills, and they're taking 30 pitches before they even hit in the field to throw 100.
and they're doing soft toss. They're should doing
Right.
long toss. They're doing spring training, right?
Mm-hmm. Mm-hmm.
Before they just go. They're doing a lot. But
Right.
people go, well, why are we talking about baseball pitching? Because we throw discs. Baseball pitcher, disc golfer, right?
Yep.
I mean,
Yep.
it's here, and we're just bent over, right?
Yep.
We're still
Mm-hmm.
we're
Mm-hmm.
doing the same thing. We're pitching, but we're just bent over, right?
And
So
if you were to freeze frame the because I had this on my disc doc Facebook page, but if you have the backhand form, it looks just like hitting a baseball, right? So you coming through and then your arm kind of coming through is just like a bat coming through the zone and loading and transferring weight from the upper to the lower. So you wouldn't go through and swing a baseball bat 400 times, after the end of, yeah, your back, I would expect it to hurt. I would expect your hip to hurt. I'd expect your wrists and your hands to hurt, right? Those
yep.
types of things.
Yep, absolutely. So next week, the Prepared Disc Golf Athlete here in the Performance Academy, we talk. Well, there's going to be a field work guide. There's going to be a in-season tournament guide. There's going to be a in-season nutrition guide. But a big thing is that field work guide, and also talking about pitch counts, and making sure that you pay attention to your volume. And now I'm going to bring up one last thing before we answer these questions. Thank you again for everyone tuning in. I know we're hitting almost 2 hours here, but this is
Oh man.
I feel quality information. We could just do this one time, or we could have like 8 of these that people need to watch. So I might as well just have one long one. All right. Uh, People, when they get injured, to them, it's an acute injury.
Mm-hmm.
But most often, a non contact injury is not acute, it's
It's been
chronic.
brewing. Right.
It's a chronic injury that's probably been either below your level of awareness, that was just creeping up, that you were putting too much stress, not enough strength, also not enough recovery,
Right.
right? And it was a chronic, and then below your level of awareness, and then all of a sudden, boom. So you're like, oh my gosh, I just went out there, I threw one forehand, and bam, now I can't move my elbow. My elbow hurts. What did I do in that moment? Like, what was the one thing that I did? It wasn't that one thing. It was chronic. It was
Yeah.
building up over time. You were not strong enough. You weren't building strength. You were too much volume, not enough recovery measures. Now, all of a sudden, now you get that one acute thing, but it was chronic. Speak to that.
Your check engine light, it goes on when it reaches a threshold, right? So a threshold is reached and then you feel it. But that doesn't mean that the program of how that's developed and for example, let's say rotator cuff strain. We talked about all the things that could contribute to rotator cuff strain. Dropping of your rib cage, rounding of your shoulder blades, breathing with your neck and chest, not having scapular mobility, not having rotation through your mid back. All those things are going to be contributing to that not being a falling out of the sky injury. That's something that's built up. That's something that is a chronic layering of all those dysfunctions, which is a nice little buzzword, but things that have kind of compensated that have led to that acute injury, that rotator cuff kind of strain. Again, this is the tip of the whip, but the handle, where that movement, where all that was initiated from is further down the chain, so to speak. So absolutely, that check engine line fires when a threshold is reached. You reach the capacity of the tendon. You've broken down and repaired it so many times that now you've gotten to a point where it's brittle and it just couldn't sustain the load that you asked it to. The shoulder was unprepared in the moment. But that was a buildup of time. That was a buildup of malpositioning, leading to bad movement patterns, leading to bad strategies I won't say bad, but improper strategies by the body, compensatory strategies by the body that then lead to excessive, usage, wear and tear, weakness, whatever it is.
Yep, absolutely.
Sorry
All
for
right.
the clock.
No, that's all good. It's soothing. No.
Yeah.
So, all right. So we have, if you're when you're watching this and you're like, okay, so I'm learning all this stuff, prehab, rehab, right? I'm learning about the breath and everything. But how is that helping with the actual recovery of the injuries? Like we talked about in the beginning, the 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 most important thing to do to rehab injuries is to one, try not to have injuries, right? And if you do have injuries, keep them at a hopefully they're at a lower level. So we can't stop ourselves from having injury sometimes, but what the stuff that we're talking about is going to help lower your risk of injury. So the
Mhm.
stuff you're learning in the academy, the prehab, the rehab exercises, we do them in the prehab. We do the bird dogs and the dead bugs and the breathing and the shoulder mobility or the shoulder stability and the upper back mobility. All that is how you try to keep yourself from having to talk to Branden or I and saying, hey, this modality of therapy, that modality of therapy. Oh my gosh, I've been injured. I've been hurting for so long. How do I, what's going on? We're going to go back and say, hey, right now you're going to build that foundation of stability and strength and recovery and all that, so that we're not having talks where we're talking about major injuries in disc golf. We're talking about minor injuries that just they suck because they take us off the course for a week or so, but they're not catastrophic injuries, right?
Right.
So when it comes to the elbow, if you're experiencing elbow pain, first thing is stop doing the thing that causes the elbow pain. Doesn't mean you don't need to you can't move your elbow, right? But you might have to take a break of throwing
Yep.
forehands if they're going to hurt your elbow, right? There's a great, not a great, I'm going to say great, but a joke that we say in the health and fitness world, right, is that someone comes into the doctor and they're hitting their thumb with a hammer and they say, Doc, I got a big problem. My thumb is killing me. Can you prescribe me a medication? Should I do, cupping? Should I do this? Should I do that? Acupuncture? Like, what's wrong? How do I fix it? And he goes, well, first thing to do is stop hitting your thumb with a hammer, right? And that's the thing. If you are feeling elbow issues and you're throwing all the time and you're not taking that hammer away, you're stressing it. You're gonna continue stressing it. So you've got to take that hammer away first before we start thinking about all the other therapies, right? So
that's it. Yeah,
awesome.
yeah, you can't just kind of load, especially when it's something like that, especially with an injury, that's where you just want to kind of build back from the ground up. And a lot of the rehab that we do, we're just looking at, well, what's the region of the body part? What's the same thing that we would do to get mobility and stability? And then we find, the pain limit or the tolerance that we can do. We regress the movement to that point, and then we build it back up.
Yep, absolutely. I love it. All right, let's get into these questions.
Definitely.
Thank you again, everyone, for being here, for watching. If you're watching live, watching on replay, we're here to support you and to really share what we've learned, both as disc golfers, but also as health, medical fitness professionals. Try to help us all be healthier disc golfers. All right, so we got one person, it came up as Facebook user. I think it was Brian, said a training regimen is always different between the off season and in season. What are some of the tips for maintaining the fitness built during a season? I find by the end of the season, my fitness is tapered off and injuries are present, trying to strike the balance between maintaining load and maintaining fitness. Mm-hmm. You want to share first and then I'll jump in?
Yeah, I'll give a little. This is probably, right up your wheelhouse. I think, especially with you designing all these programs, you've put a lot of good thought into why we do what we do. And I really appreciate working with you because you think of the why. We both think of the why, like we mentioned earlier in this, and that's so important that, there's structure to the program. There's reasons why we do these things. So, when you're in season, you got to think there's already increased load there. There's already going to be increased intensity. There's increased volume. There's increased stress. And so when you're in season, you're probably thinking about more, well, how do I recover from tournaments? How do I recover and actually, what does my Monday, Tuesday look like realistically? What's Monday, Tuesday, and Wednesday, right? And if I'm sore, then I have to take some time. If I need to just do some light stability, mobility work, that's where that kind of comes in. And so Disc Golf Strong gives you those tools to know exactly what you're doing on those days. And then when it comes to, actual tournament days, that's mental prep, that's movement prep, that's warming up, those types of things. But we're not really trying to change anything in season. I mean, you work on things, you work on technique, you're trying to make yourself better. But off season is when you can really make those gains, is when you can kind of change things, you can readdress things. And it just gives you an opportunity, kind of two different opportunities with what you're doing. So just having that intention in mind. Well, if you're in season and you're competitive, either amateur or pro, you're probably playing a lot of tournaments. And so if that's the case, we're not going to overtrain that. We're not going to try and, you got to do 4 times, 5 times a week, when you're already playing 8 rounds a week, that type of thing. So those are kind of my thoughts. And I'm sure you'll
love it. Hey, he pretty much took it all right out of my mouth. I love it, Branden. So yeah, I agree completely. Right, the off season is the off season. That's where we're training hard. We're putting in the work. We're building upon the foundation. We're expanding. In season, we're maintaining. My athletes on tour, as their in season training is 1 day a week. We'll do a moderate to higher intensity volume session based on the recovery. If they don't feel recovered, if they don't feel ready to go, they're not doing it. They're doing a low to moderate level that week, right? So it's very much based on how they're feeling, their recovery, their performance. If their performance is not where they want it, training is not the thing. It's just we're here. We're like a little bit of the icing on the cake. We're not like the cake, right? And so they need to be able to perform on the field. Same thing with you. During the season, you're working on your recovery measures. If you're fatigued, it's usually you're putting a lot of work in it, and you're expect to feel fatigued, right? Baseball players at the end, towards the end of the season, you can tell they're fatigued, right? They're putting a lot of work in, right?
Yeah.
And knowing that if you are playing a lot of tournaments, you're going to have to back off on other things. Doesn't mean you need to stop your fitness, your training. It's just, it's going to look different. And knowing that it's hard to do two things at once when it like in other areas, and just hit that recovery hard, sleep, hydration, soft tissue work, things like that. All right, Jennifer, what are your thoughts? This is right down your alley, Branden. What are your thoughts on practices like dry needling or cupping or deep tissue massage? I ask because I had dry needling done when I originally threw my lower back out 5 times in 4 months, and I really liked it. I realize it is not an end-all solution. And then she has one more. I'll ask that one after this one.
Sure. So yeah, all of those, let's just say soft tissue work, right? And there are a lot of different styles of soft tissue work. So it can be hands-on, it could be instrument assisted, it could be dry needling, it can be cupping, things like that. I personally do instrument assisted, I do cupping, I do hands-on manual, trigger point release, adhesion release, myofascial stuff. I use a hypervolt often, so I do a lot of work with that. I haven't actually gotten into a lot of dry needling myself. A lot of my colleagues have, and they, a lot of success in practice being able to access different areas and stimulate a nervous response, decreasing pain in ways that your hands can't, and ways that a pill can't. And so I find it, it's absolutely worth checking out. It's absolutely worth looking into for certain things. I would say for shoulders, for knees, for chronic inflammation, even acute inflammation. It's been shown that it's beneficial, modulating pain and getting decreased spasm, things like that. And so I think it depends on the person. Obviously, if you have a mental hang up to needles, don't do dry needling, right? But I think if you're open to it, it's absolutely a viable soft tissue. And again, it's not a cure-all, but no soft tissue work is. It's about gaining access. It's about decreasing sensitivity. And honestly, I wish I knew more about dry needling specifically, where I could speak on the mechanism, but I know that at least in the FTCA, there are a lot of docs that have learned dry needling and do that in their practice. So just by that association, I know it's something that's gaining hold. As far as cupping goes, that's myofascial decompression. And so if I'm going to do soft tissue work and I compress, if I take a cup, I can put the cup down. And then if you have this much tissue that's getting pulled up into the cup, that's actually causing a little bit of stretch to the tissue. And so that myofascial decompression is still a great way to kind of microscopically break up tissue, cause a little bit of controlled tissue damage, essentially, which is what all soft tissue work is. That then stimulates a healing response and an actual kind of recovery from the body, we'll say, fuller recovery. So dry needling stimulates that, cupping stimulates that. Really, it's just a kind of a neurologic and a mechanical stimulus when we do any sort of soft tissue work. So not to get overly nerdy, but it kind of matters what we do. It kind of doesn't matter what we do. I'm usually picking what technique I use based on the person, based on the location, based upon, how easy is it to get to with the technique that I'm using, those types of things.
Awesome. Dry needling will be legal in some places,
Sure.
not in others, like
Right.
California. I don't think there's a lot of I don't think there's any dry needling. So for those that are not sure what dry needling is, think of it like acupuncture, but not like acupuncture plus, and for like they're going deeper and they're not like putting needles all over you. So it's definitely not acupuncture, but it's taking a needle and going down into the muscle belly, where acupuncture is more right on the more surface level, and you're not going down into the muscle. So you may find a provider, you may look in wherever your state is or wherever you're at in the world and find that no one practices dry needling because
Right.
it's not approved there.
Right.
One other thing on that, Jennifer, and I know, and I'm going to say that again, I know you probably know what I'm going to say because you added it's not an end all solution, and I'm not calling you out, but I'm saying lower back, threw it out 5 times in 4 months.
Right.
That would be you. And I know that you're doing it here in the academy. You're crushing it, working on that breathing, that stability, that mobility, right? Because that for anybody. And as I go through the rest of the questions, a big part of what we're going to go through on all that is get here going strong, get here tight, use that breath, get your body in the right position to be able to handle those loads and that strength and that stress, right? So really work on that core stability, that glute activation, all that. And hopefully we don't have to, have the lower back out 5 times. But I'm glad that you are where you're at now, and you're feeling strong and healthy now. And like I said, you wrote that in there, the end all solution. So I know you knew there's going to be a little deeper, and that's just the strength coach side of me. All right, Jennifer. Also in recovery terms, but great question. Also in recovery terms, do ice baths or cold water shock also help? I know it helps slow down lactic acid development, if I have that correct.
Yeah, you see ice baths in a lot of recovery rooms, a lot of training rooms. As a general practice, I think cryotherapy and ice as a recovery piece is fine. And now, if we're using that for soreness all the time, and we're using that to always, we're always finding we're putting on our shoulder every time we come back, well, that's probably an issue, right? We're probably having pain there because we're using it improperly. And so just icing it really isn't going to be a good thing. And actually that inflammation the body's creating is kind of how it's trying to heal what you just did to it. So putting ice on is going to dull and diminish that effect. So I'm going to say it depends. If we're using it for recovery, fine. If we're using it for constant pain modulation, we got to look at why is the pain there.
Yeah, I agree with that. Absolutely. All right. Andrea said, I've had a few MCL sprains playing disc golf already, and now I have damaged my meniscus in my left knee, currently awaiting surgery. What can I do to prehab and rehab my knees to make them more stable and less prone to injury?
Yeah, great question. We already, Seth was brilliant in bringing up valgus collapse, right? And the valgus stress at the knee. And when we have an MCL, that's the medial collateral ligament. And when we talk about valgus stress at the knee, that's medial opening, essentially. So the medial part of it is open, and that ligament that attaches those two bones gets stretched and pulled. And so what we're trying to do is limit valgus collapse of the knee with any sort of movement and keep that knee in a nice stable tracking position with our lunges, with our bending, with our walking, our running. So long story short, it's going to be our glute exercises, our single leg stuff. It's going to be our balance exercises. It's going to be ensuring that we're not kind of collapsing in with our knee and working on our glute and core stability.
Yep, absolutely. And if you have an instability in the knee, if you feel that your knee feels unstable when you're on it, you might want to look into using a sleeve or a brace or something when you're doing some movements, not as a fix, but just if your knee feels very unstable. What are your thoughts on that, Branden?
Yeah, I would say, my preference and what I tell people is the brace is meant if you don't have the hardware, right? But it's kind of a mixed bag. You would have to convince me on why a brace works for you, not necessarily me being able to give a blanket statement on braces. So generally speaking, I'm going to want someone to have the inherent natural stability of their own movement without a brace. Now, if we have a knee that has already had surgery, or it's arthritic, or there's excessive motion and movement and we're trying to stabilize, well, in competition it makes sense to wear a brace, right? Now when you're working out, it doesn't necessarily make as much sense, because we want to develop that stability organically. And if the brace is there, we're never going to learn how to stabilize, because it's bracing, it's stabilizing. So the joint doesn't move as much, doesn't have as much sensory information. So there's a dulling down or diminishing of how much we can actually control. So, my nerdy answer is braces. Really, it depends, and you have to sell me on it. In certain scenarios where there is instability, obviously post-surgical, your doctor tells you to wear a brace, wear the brace, right? You sprain it and you're feeling like, if I step on my knee, it's going to give out right after an injury, wear the brace, right? But short of that, long-term bracing, I wouldn't say is a solution.
Yep, right with you. Awesome. All right, great question, Andrea. Jennifer, what do you recommend for cool down after a round? Yeah, great question. I would say first thing I do is I have my athletes do some soft tissue work, some foam rolling, more of a restorative recovery type of foam rolling. They're not, trying to hit every single point. That's just they like it. It feels good after they're done with their round to just go and lay on the mat, spend a couple minutes rolling on the muscles, right? This just feels good for them. Now I have my ringer going off my phone.
Yeah.
Then we work on a little bit of stability work, especially for their shoulder, because they've just spent the entire round doing a bunch of things that could get some laxity in that joint. So we'll do some shoulder taps. We'll do a few stability exercises for them. And then for different parts of their body. And then we will roll out the bottom of their feet most of the time, or I have them walk on a rock mat, just a fake mat that looks like rocks. Just, they've been wearing shoes and they've been, the whole time put a lot of stress in their feet. So try to just work on some mobility. And then finally, we always finish out with some deep belly breathing, some diaphragmatic breathing, and then drinking water, hydrating right away. You've been dehydrated over the course of the round. Most people will. And then start your recovery process with some good, some music, get yourself chilled down and get some good sleep.
Yep.
So what do you have to add to that?
Yeah, bring yourself down, bring down the adrenaline, bring down the heart rate. I think the breathing is a great way to end, because pretty much everything that I do in the training room or in my rehab room at my clinic ends with some sort of either child's pose, just laying face up breathing, or I have them do the PRI 90-90 hip lift, any of our breathing exercises basically. But that breathing just gets their core back to activation. It gets their mental brought back down. It gets, if they're jacked up from competition and they're kind of sympathetically driven, which is that fight or flight, we want to bring them down more rest and digest, which is how they're going to actually recover. So the breathing is huge to get them into that parasympathetic, calm, rest and digest state, so their muscles can recover, their mental can recover, all those things. So, yep.
Perfect. Love it. Okay. Great question, Jennifer. Okay. Stefan, I think it is. I went to the chiropractor recently for sciatica pain, and I found I have a lateral pelvic tilt. My left hip is 10 millimeters higher. I wonder if disc golf could be the culprit somehow, or probably my office chair from prolonged sitting.
It's interesting because my head goes to PRI. Anytime I hear an asymmetry like this, what you're telling me is that your left side's higher, right side is lower. Sorry, it's probably off on the screen. So left side higher, right side lower. And so you're living more on your right side. You're shifted more into that right side, and you're probably more comfortable, loading the right side of the core. And I'm making some pretty rapid assumptions here, but that class that Seth and I alluded to that we took a year ago really gave me that pattern that it's not that this is just a static thing. This is a dynamic thing. This isn't you were just born, I don't think, with a 1 centimeter different length of a leg, but functionally you have adapted to more movement strategies that load your right side versus your left side. And so, sure, it could be a little bit of a product of disc golf if you're bracing into the right side constantly. But I would say it's probably a product of a lot of other things too. Probably how you move in your regular life is how you move in disc golf, if that makes sense. And it all ties into itself. So summarizing that long little bit of an answer is that there's probably an inherent functional compensation that's not necessarily abnormal, but could be addressed through some left-sided loading to kind of bring that left side down again. And it's nothing that, in my opinion, is just going to go away from only adjusting. This is right. And I might be touching on a little bit of a hot issue. Maybe this is for the next call or the later call, another time. But a lot of chiropractors might have you come back to treat that unlevel hip, and it might feel good to get it adjusted, but that's not the long-term approach.
Sounds like maybe they should be doing some deep diaphragmatic breathing, some glute bridges, some hip stability work. They're definitely a
Yep.
theme. Awesome.
And this is coming as a chiropractor saying that.
Yeah, perfect. Great question. Lance, my hips aren't level either. Most of us are a little off in one way or another. You want to speak to anything on that, or kind of just same thing you just
Yeah,
said is?
within normal limits, we're going to have some asymmetries. And I would expect, honestly, half of the pros that we treat, and this, what makes them good is they're asymmetric. It is what it is. What makes us really good at throwing with our right hand is we can engage all those tissues at once in that rotation, but our left side feels awkward for a reason because we haven't developed that pattern. We're stuck to the right. It's just how we live our lives. And so it's not surprising to me to hear about asymmetries like that because sometimes it's what makes us good at what we do.
The best athletes in the world are the best compensators in the world,
Yeah,
right?
absolutely.
So, all right. Jennifer, also to recovery using foam rollers and other balls and things like that. Personally, I found them wonderful, but just curious to your thoughts. Yeah, absolutely. I'm a huge fan of soft tissue work. Now, I would say that when we're doing soft tissue work, like foam rolling and using lacrosse balls and things like that, um, we're not really breaking up like scar tissue. We're not really even affecting much of like a change of like fascial tissue, like knots, like so foam rolling is can be beneficial. It can feel good. It can kind of tone our muscles down, like take some of the tone out of our muscles, some of the tension in the moment, right? And it's good to just kind of move the blood, get the blood, move the blood flow, and the muscles, things like that. It can help in recovery. Like I said, it feels good. Now you want to impact more of a change with soft tissue work. You definitely want to see someone like Dr. Branden to actually get in there. But yeah, thoughts on that?
Totally. Increases circulation, decreases tissue sensitivity. That's, it's not necessarily about changing anything that's elastic. It's about, kind of squeezing and pumping tight tissue. So it acts and it kind of perfuses fluid better and there's more circulation, more healing. It's about dynamically warming up tissue and kind of preparing for movement. And then it's about reducing tissue sensitivity. So it's more the neurologic prep for movement. And so the repeated, passing over a region 15, 20 times, something like that. It's going to neurologically diminish pain. So there's less resistance, less of that check engine light to movement. And so you actually have full access to your movement patterns. I'm actually getting a blinking battery light here. So I probably have time for a few more.
Okay, let's hit through them real quick. All right. Lance said, do you have any specific recommendations for meniscus injuries? Just had surgery to clean up old damage and a tear. Say you'd try to say hip stability work again, right?
Hip stability, yeah, we talked and touched upon this. I know it's a long video, but the knee is not supposed to be excessively moving. And so really we want to keep that knee nice and locked and stable. So when you're going through things like lunges and deadlifts and squats and all those types of things, we're looking for almost as little knee movement as possible. And then the movement should be coming from your ankle and your hip. And so when you're working on everything that Seth's kind of giving you focus on that ankle and that hip, for balance and stability, and your knee is going to work itself out.
Yep. Awesome. And I would say last thing there, Lance, is timetables. Don't try to push things too fast. Trust the process. Go through your rehab. Strengthen it. Don't just jump right into something. Okay. Lance said the shoulder exercise are the ones I have most difficulty with when doing floor slides. I want to lift my neck as I reach the lowest point. The overheads are just hard to get to the floor on the right side. Do a lot of breath work as you do that too. You can hit a lacrosse ball in the pec and stuff too. Before you go into your floor slides, kind of just reduce some of the tension and traps. A lot, really focus on breathing in and then do it.
Yeah, with that breathing, I'm going to say make sure that you're posterior pelvic tilting because I'm imagining the ribs flaring up and that's putting them out of position. And so I'm imagining needing almost like that exercise we talked about in the beginning where you flatten your spine, posterior pelvic tilt, and tuck your abs like Seth just mentioned. Make sure that that's incorporated with your exercise.
Okay, we got shocked how much the hip hinges come into play in my putting. Absolutely. Drill that hip hinge. Let's see. Iris said history of slightly rotated tibia, some knee pain with not being able to bend it as far. Is there anything done to prevent injury? Slightly rotated tibia. Do you think want to go see someone like you to get some work done?
Yeah, that's an interesting one. That sounds, I mean, that again, that's a static thing in a dynamic world, right? And so I would have to look and see if that's something that's going to change or not, right? And if it
Okay.
doesn't change, then what's the strategy to work around it? If it does change, then it's more of a functional rotation, and maybe that again is coming from the first thing I think of is ankle. I'm thinking of either arch or, that ankle collapsing in and how that's rotating the tibia above it. And so if you don't have proper arch support or your foot kind of collapses in, then I can see that being a rotational issue at the tibia. So that might be kind of the first thing we work on is just that ankle strength, that glute and ankle connection, those types of things.
Okay, awesome. Mike says, thank you both so much for sharing your time and wisdom. 3 weeks in the academy, feel the difference. Just forget disc golf. I feel like I'm a healthier human. It's a big thing, become a better functioning and optimized human, and you become a better disc golfer. Dawson, I have a question about injury reduction with throwing big anhyzer backhands. I threw one the other day. Afterward, had chest pointing at the end of my exhale when putting my arms behind my back.
Okay. Sounds like a thoracic muscle strain. It sounds like either rhomboid or serratus, which again, we're just name dropping muscles, but basically the muscles between the shoulder blades, the muscles between the ribs. Anytime that you're kind of overarching, and I'm imagining a scenario where you're probably kind of loaded that back to twist and get over on the disc a little bit. And so it could have just been a straining kind of thing. So then when you pull back, there's, some pain there. That's, as long as it's mild, you can foam roll that. If it's getting severe, it prevents you from taking a deep breath. That's where you see a chiropractor or physical therapist.
Yep, and get in strong. Work on the strength. So when you throw those big anhyzer backhands, you can handle it.
Yep.
All right.
Well,
Someone
and
said
that
I can't.
thoracic
Thoracic
mobility,
mobility.
I would say. Yep.
Yep. All right, we're almost done. I know. Tell me if you're about to get turned off here
I
with
think
the
that's
battery.
7%, 6%. Yeah.
Okay, we're almost done. We're at the end. Constantly
Nice.
have neck kinks or pain. When I stretch it or try to pop it, I can feel it from the back of my skull through my shoulder blade. Is this usually just stress and posture related, or is it common to have other underlying shoulder neck issues?
Yeah, great question. And I think it's a multifaceted answer. It's is it posture and stress? Yes, in a sense. We kind of talked about if we're breathing up into our neck and our chest, and if we're stressed when we're breathing, then that's going to feed into that. If we're talking postural stress, so more the mechanical, I kind of alluded to it before, but prolonged positions, right? It's not the wrong position, it's prolonged position. So it's prolonged exposure to the same position without ever breaking that cycle. It's not like you're meant to just sit like this all day in this military erect, stiffened posture, but we're supposed to flux between this and be able to accommodate different postures and positions and break that cycle. So, if you always have knots in your neck, I'm thinking a neck that doesn't know how to turn off. Why does a neck not know how to turn off? Because it's trying to hold up a head, right? So we need to break the cycle of how much demand is going either posturally. So maybe it's looking at your workstation, making sure ergonomically you're not just looking down, that it suits your body type, that your chair height, your screen height, all that type of stuff. When it comes to thoracic mobility, that if your mid back doesn't move, then your neck excessively moves. And then every time you go to bend forward, the neck is the tip of the whip. The neck is the thing that's getting all that load when you're going to go lift your back up or lift that laundry basket or lift your kid or whatever it is. Your neck is kind of having to tighten in order to brace for a lot of that. So kind of a long-winded answer, but hopefully I touched upon some things there.
And if you're like this, you got to get your head up somehow.
Yeah. Yeah.
Right. So you're
Yep.
going to crane that neck up. Right. All right.
Yep.
Wrapping up here. Lance said he has a torn right ACL and he wears a brace to play, but doesn't when he works out.
Okay.
Jennifer said, thank you for the information from the beginning to the end. Really appreciate it. Thank you for your specific answers. It's been a really informative night. So thank you. Thank you, Jennifer, for being here and for those great questions. Iris, is there a way to fix that foam rolling tends to really hurt, especially the IT band? I would say with that is there was a study they found that to actually like get change like on your IT band, like you needed 23,000 pounds of like force. Like we can't elicit change on our IT band. And really the IT band is, oh, did I just lose him? I think I lost him. The IT band is just tissue here, right? That is very thin that is in between the bone and the skin. So there's really not much there, right? Let me take Branden off. Oh man, thank you, Branden, so much for being here. Oh, he just messaged me that his computer died. Truly appreciate you being here. I'll finish these last questions here. So the IT band, you're not really going to be able to massage to foam roll that IT band and elicit change. You can roll up near your hip socket area, but don't actually roll on your IT band. It really just causes pain for people. I used to roll on my IT band and then realized, found the research said you're not really doing anything that's beneficial for you by rolling your IT band. And then Lance, great session, guys. My yoga instructor wife was impressed. Thank you. Thanks for tuning in, both of you. All right, we're going to finish it out here. Again, a big thank you to Dr. Branden Garland for being here and being part of not only the Performance Academy, but also being a part of what we're doing here at Disc Golf Strong. He's been played a critical role in in our conversations, him and I, and the things that we've learned and talked about. So thank you for all the great information that you brought here, Branden. And thank all of you for being here. Truly appreciate it. I hope you enjoyed it. Hope you got some great information. And let's keep going strong. Final message is, as we know, right? Keep the body healthy, and then we reduce the injuries, right? We reduce our level of injuries. Go back to those foundations, drill those foundations, core stability, breathing, right? Not jumping into things that is just all about, maximizing intensity and stuff. Build those foundations. We want a prehab, we want a rehab. All right, that's it. Gone long enough. Again, thank you, Performance Academy. We are so excited to be continuing this journey with you, and that you're on this journey with us to becoming not only better functioning disc golfers and moving optimally, but also better functioning and more optimally moving human beings. All right. Have a great night. Keep going strong. Train disc golf strong so that we can continue to play disc golf strong. Good night, everyone.